The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, TMD warriors. Good day to you. For me, it's another Tuesday morning, recording the next episode of TMD Demystified, and my name is Tony Urbanek. For the few of you who are not familiar with my podcast, I'm an oral and maxillofacial surgeon who trained at Vanderbilt, a medical degree at Vanderbilt, dental degree at Indiana, cell biology degrees at Indiana, fellow with the NIH for 2 years in facial growth and development. And in my private practice career, did over 2,000 temporomandibular joint surgical cases, basically half of them open joint surgeries through an incision in front of the ear of various types and varieties, and the other half through an arthroscope. I have lots of experience with surgery, and 14 years ago, I decided surgery was not going to be the answer because a third of the patients that I did surgery on would be back within a year or two with the same symptoms. And I did a research project of my own and actually discovered what was really going on with TMD. I discovered the actual pathological process, and that was a discovery that was already in the textbooks. It was already in the literature. The dots just need to be connected. And that's my claim, and we have proven that with in many different ways. We have a independent university study based on 3,000 successfully treated patients. But I am here to talk to you today on a topic that may seem kind of pedantic, but please let me explain. Today's title will be, what are nociceptors and why are they important to understanding TMD? For you doctors out there who took a histology course at some point in your career, you should know what a nociceptor is. And for the public who I understand view many of these episodes, a nociceptor is defined as a nerve ending of one kind or another that perceives pain. Nocere in Latin means pain. And you know, doctors have to speak in Latin terms to sound important. So instead of saying pain receptors, we say nociceptors. That's a fact. So we're going to talk about nociceptors. So nociceptors are cell types that are located in various portions throughout the body, both the external body, arms, legs, internal structures of some varieties, mucosa. So they be located in the mucosa of the stomach, mucosa intraorally. And they're also located, nociceptors, pain receptors, are located regarding the bone. They are located in the marrow of the bone, and they're located in what is called the periosteum of the bone, which is the covering of the bone, but not located in bone itself. And the periosteum, or covering of the bone, has a more than sufficient great number of nociceptors in them. If you are a dentist, you are well familiar with this phenomenon of nociceptors and how significant a response you get when they are stimulated. You can prove it to yourself every time you do a mandibular block, local anesthesia, through the mouth and to block the inferior alveolar nerve. when you place your needle through the mucosa, you get very little response because there are a lesser number of nociceptors in the mucosa than there are in the periosteum. So when you do your block, you take your syringe with a hopefully sharp needle on the end of it, and when you place it through the mucosa, you rarely get a patient's drawback or response. But if you go a little bit too far and that needle touches the periosteum on the medial aspect of the ramus of the mandible, that is when the patient will draw back. And that is a great example of the response of nociceptors. And it is a response of the mechanical response. There are different types of nociceptors that respond to chemical injury, pressure injury, different types of injury, but the nociceptors in the periosteum are more likely to respond to mechanical injury. And I think that is why they're called mechanoreceptors. But anyway, a nociceptor is very, very interesting to fully understand TMD. So let me explain. I will try to be simple and I'll try to be very direct. Let me first of all make a review of what's really going on, what really is the pathological tract of the symptoms of TMD. Again, for review, the symptoms of TMD include, and no one disagrees with this comment, the symptoms of TMD, and you don't have to have all the symptoms, but most people have many of them: frequent or recurring headache, earache, jaw pain, neck pain, tinnitus, ringing in the ears, subjective hearing loss, a feeling of fullness in the ears like you've been swimming and can't clear your ear, dizziness, vertigo, upper back and shoulder pain and tightness or tightness, arm, hand, finger tingling or numbness, and various kinds of jaw locking. Those are the well-accepted symptoms of TMD, which are very disparate symptoms, and they can occur in one patient. In fact, we frequently see all of those patients, all of those symptoms in a single patient. And for our medical colleagues, my medical colleagues, and the patient comes in with various symptoms on that list, medical doctor just says, "You must be crazy." And most dentists don't want anything to do with TMD because they don't understand it, or they don't understand it and prescribe a night guard and hope the patient doesn't come back. But the point is, those are the symptoms of TMD, and how do those symptoms originate from some kind of damage to the temporomandibular joint? Well, damage to the temporomandibular joint, the common denominator to damage of any kind is inflammation. When the body in any way, shape, or form becomes damaged, the immediate response is inflammation. If the inflammation doesn't go on a routine basis to full and complete healing, it is called chronic inflammation. And that is exactly what you see in each and every patient who has TMD, temporomandibular joint disorder. They develop sooner or later chronic inflammation within the temporomandibular joint. How do I know that? I know that because after 2,000 temporomandibular joint surgical cases, each and every one of those cases, a piece of tissue was sent to the pathologist. That is standard operating procedure in any operating room. A piece of tissue is taken from the surgical site and sent to the operating room for review. And in each of those 2,000 cases, the pathologic path review returned as line 1, chronic inflammation, or description of the cell types that were equal to chronic inflammation. No matter what else that pathology report included, first line was always chronic inflammation. So after 2,000 cases, without exception, you can deduce that if you have TMD, you have chronic inflammation within the temporomandibular joint. So what happens when the temporomandibular joint is inflamed? Well, those were the dots that were connected. It's in the literature. The autonomic nervous system plays an extremely important part in this. When a joint, whether it be elbow, hip, knee, or temporomandibular joint, becomes chronically inflamed, it sends a signal to the brain that says, "I'm inflamed." The brain modulates that signal in an attempt to help healing, sends a signal back down to the muscles that move that joint, in this case, temporomandibular joint, that says, don't move the joint. Tighten the muscles that move the joint. Tighten up. Constrict the muscles. Don't move that joint, in an attempt to help healing. And when those signals come down, and they always don't come down to the same muscles at the same time, they come down to various muscles, different muscles over time. It first comes down to the muscles that move the jaw. There are 5 major muscles that move the jaw. Our dental friends know the names of those. Hopefully you do. And the patients complain of different various pains around the face and oral cavity, and they will point generally to the point where the muscles getting the signal to get tight attach to the bone. Hopefully you see where I'm going with this. The muscles get signals to tighten up, to constrict, and where those muscles attach to the bone, even either the origin of the muscle or the insertion of the muscle, they pull on the periosteum and stimulate the nociceptors. They stimulate the nociceptors. And when the nociceptors are stimulated by the excess and continuous pulling on the periosteum by the muscles, it will create pain, and patients will complain of various pains in various areas of the face, origin insertion of the muscles of mastication. When the chronic inflammation doesn't subside, the pain is ignored, or you go to a provider that does something that doesn't work, or isn't significant in the treatment of TMD. Best example I can think of is Botox. Frankly, I will say openly, Botox is a scam. And topic isn't Botox today, which is botulinum toxin A. The generic is botulinum toxin A. There are other brand names for botulinum toxin A. Botox is just the most well-known. Everyone refers to botulinum toxin A as Botox. Everyone in the country uses Botox if they're going to use botulinum toxin A as the name of it, although there are several other names. But there is a recent article, I pulled it out just recently, and we're not going to talk about Botox, but this is an article from the Journal of Oral and Maxillofacial Surgery, extremely well done article. I've noted it before, but I give it to you as an example of trying to treat symptoms of TMD without treating the cause. And this is a good example of trying to treat a symptoms. Yes, if you paralyze a muscle that has been given the signal to tighten up, it won't pull on the bone and therefore will not stimulate the nociceptors. However, the signals move around to other muscles. So you're basically chasing the signals, the nervous signals, to various muscles. So sometimes it'll hurt here at the insertion of the masseter muscle, or it can hurt here at the insertion of the temporalis muscle, or it can hurt here at the insertion of the mylohyoid muscle, or the medial lateral pterygoids, where patients will always complain of pain right in their doctor, but they don't always complain of pain there. It can move around. So if you use Botox, botulinum toxin A, and paralyze this muscle, what about tomorrow when it hurts over here? You're basically just chasing the symptoms. As noted on previous episodes, I've talked about a patient I had who she and her insurance company spent over $200,000 on Botox over 10 years, and she finally was sitting in my office, in my chair, examination chair, to get an actual significant permanent relief from her symptoms by attacking the chronic inflammation, which is in the temporomandibular joint. Decreasing chronic inflammation adequately will decrease all of the symptoms, not just painful symptoms. It will also decrease tinnitus, subjective hearing loss, and vertigo, because the inflammation creates the nervous signal that stimulates the muscles. And in the case of tinnitus, subjective hearing loss, and vertigo, decreases inflammation within the joint, which no longer forces inflammatory fluid through the petrotympanic fissure into the middle ear.